Welcome to this podcast entitled Selected Bioavailability and Pharmacokinetic Calculations. And before we go any further, clearly we're going to need to define both of those terms, both pharmacokinetic and bioavailability, because at this point in your pharmacy school education, it's unlikely that you've had much exposure to those. So let's just define pharmacokinetics to begin with. Pharmacokinetics is a branch, actually, of pharmacology that's dedicated to determine the fate of a drug once it's been administered to the living organism. Now, pharmacokinetics has been described as explaining what the body does to a drug and refers to the movement of the drug both getting into the body, being spread around throughout the body, and then lastly coming out of the body. That is, pharmacokinetics deals with the time course of several aspects of drug delivery. It involves the absorption of a drug, its bioavailability to be absorbed in the first place, the distribution, metabolism, and excretion. So think of the time course as that if you were to swallow a tablet, the tablet has to dissolve and disperse and be able to be absorbed through the GI lining. So that includes first bioavailability, that is the ability of the drug to be released from the tablet, and then also the absorption, the ability to go from the GI tract through the GI system and into the blood, and then distribution, which is the way that the drug can be distributed throughout the body through the blood system. Then metabolism, which is the way the body will inactivate or break down the drug. And lastly, the excretion, whether it's through the GI tract or through the renal system, the body does finally get rid of that drug. So that is essentially the study of pharmacokinetics. And it's an extremely complicated and fascinating topic. You will take at least 2 semesters just on that topic. There's pharmacokinetics, and then there's clinical pharmacokinetics, which is more of a practical application of these principles. So one other last thing is make sure I did define the term bioavailability, because some of the questions, the next question is specifically about that. And bioavailability is really just a section of the absorption that we talked about with the tablet. And it's defined as the rate and the extent to which the active ingredient or active moiety is absorbed from a drug product to become available to be absorbed. So it's the release of the drug from the drug product to then allow the absorption to occur. So you can see where that is tied into the absorption part to the pharmacokinetics. So all I want to make sure I explain at this point is the purpose of this podcast and this chapter is not to teach you pharmacokinetics or make you an expert in bioavailability. More importantly, I think it is to kind of let you see some of these topics in advance, kind of a preview. They're, I think, very interesting, but more importantly, try to highlight to you where you still need strong calculation solving skills. You need to be good at math. And essentially, even if in the questions I'm going to do here in a little bit don't understand the real background or why is this really going to work or how did that come about, you won't know the depth to understand it. But if I can help you to at least set up the equation and help you see how you would put the different variables in the different parts of the equation, then your math skills should be sufficient enough to solve them. So this is one of those chapters that will show you that the skills that you've been learning throughout this course are going to be applied in a variety of different ways, not the least of which is pharmacokinetics. So with that as a bit of a background, let's go ahead and start with our first question. All right, well, this is our first question, and it's a question about bioavailability and bioequivalence. So before we even read the question, I want to go ahead and give it a little more background. I described a little bit of bioavailability already. So going forward, though, realize bioavailability in our equations is going to be represented by the variable capital F. I have no idea why, but F is the term that they typically use to represent bioavailability in our equations. So keep that in mind. And I'll remind you, bioavailability is the subcategory of absorption, and it represents the fraction of an administered dose of a drug that reaches systemic circulation. It reaches the blood. So if you swallow a pill, the pill has to dissolve, it goes through the GI tract, and before it reaches the blood. Well, what if you put a cream and rub a cream on your skin? Well, that drug has to go through the dermis layer and through the skin to be able to be ultimately absorbed into the blood. So regardless of how you're administering the drug, its bioavailability represents the ability of a dose, whatever amount of dose you give, to actually reach the blood, the systemic circulation. Okay, so this is a key principle within pharmacokinetics. Since the first thing we worry about in pharmacokinetics is absorption, then clearly bioavailability will affect absorption. Okay, now, given that definition, it should make sense that when a medication is administered IV or intravenously, its bioavailability is 100% because you're already putting it directly into the blood, which is what we're trying to accomplish when we administer drugs by other routes. Okay, so a IV is 100% bioavailability. However, when a medication is administered by other routes, such as orally, its bioavailability generally decreases due to some degree of incomplete absorption and first-pass metabolism in the GI tract. I'll just mention that, is that even when a drug through the GI tract gets absorbed into the blood, most of that blood goes directly to the liver, so the liver has a chance to inactivate it before it even gets to the general circulation. So all of these things kind of affect how much of a dose of a drug actually makes it into the blood to reach distant targets. All right? And this amount can actually vary from patient to patient. So not all bioavailability amounts are the same for everyone. Now, bioavailability, again, is one of the essential tools used in pharmacokinetics and must be considered when you calculate dosages for non-intravenous routes of administration. Okay, so that was bioavailability. Just briefly about the term bioequivalence, it's kind of a slightly different term. Bioequivalence is a term used in pharmacokinetics to assess the expected equivalency of two different preparations of the same drug. If the two products are said to be bioequivalent, it means that they would be expected to be, for all intensive purposes, the same and produce the same effect. Okay, and that's clearly kind of what we're doing in this question when we're going to be comparing what we get from a tablet versus what we get from an elixir. And to do that in this question, I've chosen to use the drug phenobarbital. And just a little bit of background about phenobarbital is that it's a really old drug. And it was, a long time ago, was the most commonly used anticonvulsant. Not so much anymore, but for a long time it was very commonly used. It's been around forever. Like I said, it was first used as an anticonvulsant in 1912 and was actually approved by the FDA in 1939 upon creation of the FDA. Now, in general, phenobarbital was used to treat all sorts of seizures except the absence or petit mal seizures. It was regularly prescribed to prevent febrile seizures. However, its use now for all of these purposes has certainly almost been replaced by newer agents. And it's not like phenobarbital wasn't effective, it just had a lot of side effects. And so a lot of the newer drugs have fewer side effects and probably even a little bit more effective. And especially in some of the anticonvulsants in children, phenobarbital was associated with a slight decrease in the effects, or had an effect on learning, which obviously no parent wants to have in their child. So newer drugs have replaced phenobarbital. But the reason I want to just bring that up here is it makes for a good example. It's been around for a long time, and it is commercially available both in tablets, as you can see in this image here, in this case a 15 milligram tablet, as well as in a liquid form in an elixir. And so it's the same drug, phenobarbital, in a tablet, same drug in the elixir. So what this question is really relating to is, if you're going to want to get an exact dose for a patient, would you get that dose? Would it be the same whether you give them a tablet, or would it be the same as an elixir? And the answer is no, because the bioavailability from those two different dosage forms of the same drug is not necessarily the same. So let's read the question now. Hopefully that sets that up. The question says, if 5 milliliters of an elixir containing 2 milligrams per milliliter of a drug, in this case phenobarbital, is bioequivalent to a 15 milligram tablet having a bioavailability factor of 0.6, what is the bioavailability factor of the elixir? Okay, and remember we said the bioequivalent means it's the same thing. So we're trying to say the 15 milligram dose of the tablet would be the same as the 5 milliliters of the 2 milligrams per mil dose of the phenobarbital elixir. But those two numbers are the same, so clearly if they produce the same effect, their bioavailabilities must not be exactly the same. So can we solve for that? Can we find the bioavailability of the elixir? So let's just rewrite what we know so we can solve this question. Let's start with the tablet. We know that the tablet dose is 15 milligrams. That's the amount of phenobarbital in that tablet. We were also given that the bioavailability factor for phenobarbital tablet is 0.6. And understand that that's given to us as a decimal, but we could re-express that decimal as a percent. So 0.6 is essentially the same as 60%. And the only reason I'm trying to explain this to you is that we're basically saying with this bioavailability factor is that if you give somebody a tablet that contains 15 milligrams, it's not all going to be hit the bloodstream. There is enough problems with the tablet dissolving and some breakdown in the first pass metabolism that only 60% of that dose actually makes the blood to go to the brain in the case of treating a seizure, if you will. Okay, so a bioavailability factor of 0.6 means 60% of the drug makes it in. All right. Now, we're saying, though, the question tells us that that situation is the same as giving an elixir of phenobarbital, where we give 5 milliliter dose of the elixir that has a concentration at 2 milligrams per milliliter. So the question is, can we solve for the bioavailability factor? What percent of the drug is absorbed when the drug is given as an elixir compared to the 60% we said when it's given as a tablet? So that's the question we're trying to solve. So let's do that. So to go forward on that, I would say that here's that information having been rewritten from before. Our first step, though, before we even mess with the bioavailability, is let's actually figure the dose from the elixir. We know the dose from the tablet is 15 milligrams. So let's go ahead and solve that same thing from the elixir. So we just set up the equation and say, all right, we were told that we're going to give a 5 milliliter dose, and we multiply that by its concentration expressed as 2 milligrams per milliliter so that the milliliter units cancel. And you can see that 5 times 2 gives us 10 milligrams. So what we're really talking about from the elixir is a 10 milligram dose. Okay, now step 2 will be to actually determine the bioavailability factor for the elixir. To do that, this is the equation we would use, because we were told that they were bioequivalent. So we know that the elixir at its dose and bioavailability factor is equal to the tablet dose times its bioavailability factor. We were told that they were bioequivalent. So we can use the formula that the F, or the bioavailability factor of the tablet, times the dose of the tablet would equal the bioavailability factor of the elixir times the dose for the elixir. Okay, so that's what I mean by knowing enough of the bioavailability and the pharmacokinetics to set up the equation. Then you should certainly have the math skills to solve this. So I think you do. Let's go ahead and solve this. So here's my initial setup. Let's start on the left-hand side and with the tablet, and realize what we've done is the question told us that the bioavailability factor for the tablet was 0.6. So we're going to take 0.6 times the dose for the tablet, which is 15 milligrams. And then we're going to set that equal to, and we said that's the same as if we give a, in this case, 10 milligram dose of the elixir, that's the number we just calculated from above, times its bioavailability factor, which we don't know. So we set that equal to X. So X represents the bioavailability factor for the elixir. Now we need to do just some simple math to solve for X. And if we do that, if we take 0.6 times 15 and divide that by 10, mathematically you should set X equal to 0.9, which is kind of interesting. Remember how I said that's the decimal representative of the bioavailability factor, but we can change that to a percentage. That means that essentially 90% of a dose from the elixir is absorbed, compared to the 60% rather, percent of the dose from a tablet. So clearly liquids, in this case an elixir form of phenobarbital, is a much more effective way of getting drug actually into the blood. It's absorbed better from the liquid than it is from the tablet. And that's the case for many other drugs as well. However, does that mean you should always only give elixir? No. Elixirs don't taste very good, and they may not be as easy and convenient to take. So instead of using the elixir, we can use the tablets, but we have to adjust the dose. Since it's not going to be absorbed as well, that's why we had to give a 15 milligram dose from the tablet, whereas we could get away with a 10 milligram dose from the elixir since it was absorbed better. So these brings up the whole role of the pharmacist in trying to make sure that the patient gets the right dose for their medicine, and oftentimes that dose depends on the actual dosage form that they'll be administering. All right, this next question takes a little bit us further down the road into pharmacokinetics. The question we just completed was about absorption and bioavailability. This question goes the next step into drug distribution. That is, once the drug is absorbed into the blood, how does it go around through the blood to all the different parts of the body where it might need to produce its effects? So we're talking about the distribution within the blood. And there is a very key concept for the distribution part, and I would point you to kind of the picture in the top right as I try to describe this, is that a blood, once it's in the blood, actually exists in two forms, bound and unbound. Now, depending on the specific drug's affinity for plasma protein, a certain proportion of the drug may become bound to plasma proteins, while the remainder will be unbound. Plasma protein binding refers to the degree to which the medications attach to proteins within the blood. Now, this is important because a drug's efficacy may be affected by the degree to which it binds to these plasma proteins. Meaning, the less bound a drug is, the more efficacy it can have because it's available to actually transverse through the cell membranes and get out of the blood and into the organs and the tissues it needs to produce its effects. Conversely, the more highly bound a drug is to these plasma proteins, the less unbound drug is available to actually leave the blood and actually produce an effect. Okay? And lastly, some common blood proteins that drugs bind to in human blood are the human serum albumin or lipoprotein, glycoprotein, and various types of globulins. So with that as a background, this importance of how much of a drug is bound versus unbound, let's read this question and see if we can approach it. It says, if at equilibrium, 2/3 of the amount of a drug substance in the blood is bound to protein, what would the alpha or A value be for the drug? Okay, now I haven't explained what an alpha value is, and we'll get to that, but let's go through some other definitions first to even get to understand what an alpha value is. So the first things we need to know to answer this question is let's define various concentrations. So the first concentration we'll describe is called CT, which stands for the concentration of the total drug in plasma. Okay, so it's the total drug plasma concentration, whether it's bound or unbound, it doesn't matter, it's the total concentration in the plasma. The second concentration would be a fraction of that. CB stands for the bound drug concentration, or the concentration of drug in the blood that is not bound to different plasma proteins. That leaves the last fraction, which is the CU, or the concentration of unbound drug. So this is the free drug, not bound, that would be available to cross out of the blood and into the body to produce its effects. Okay, so with those three different concentrations, it should make sense, if we look at the formula on the bottom left, that the CT, or the concentration total for all of the drug in the plasma, is equal to the sum of both the concentration that's bound, CB, plus the concentration that is unbound, CU. Since it's either one or the other, the amount of the drug in the blood is either bound or unbound. When you add up both the concentration bound to the concentration unbound, you get the total concentration. That's probably pretty straightforward. Now, the whole point of this is we want to calculate an alpha, or what they call an A value. And simply, by definition, that is the concentration of the unbound amount of drug divided by the concentration total. So essentially, it's expressing to you the percent of the total of the amount of drug that's unbound in the plasma. And that's important because I'll remind you, we said that a drug's efficacy depends on how much is unbound. So drugs with a large alpha, with a large percentage unbound, are going to be more effective and produce a greater effect than a drug that has a low alpha, meaning there's not much unbound relative to the total, meaning there's not much free drug to be able to cross and produce an effect. So that's why this A, or this alpha value, can be important in pharmacokinetics. So let's now try to answer this question with that little bit of background. So with that, we'll go and remind you of some of those concentration definitions. But let's start. Our first step is simply to address the question that said that 2/3 of a drug substance in the blood is bound to protein, meaning CB. So let's use our formula here. That was the total is equal to the amount bound plus the amount unbound. And let's put some numbers to that. And this is where, since it's kind of an idealistic question, it can be difficult. But let's start with the total. Since the question gave us the amount bound in a fraction, meaning 2/3, let's kind of express the amount total then as, if you think of it as a percent, 100% would be 1. Okay, so 1 represents 100% the total amount of drug in the plasma. Okay, so we know the total is 1. We were told, therefore, that the amount bound for this particular drug is 2/3. 2/3 of the total will be bound. So with just a little bit of math, if we just subtract the bound from the total, so if we took 1 minus 2/3, so 1 meaning 3/3 minus 2/3, that means what's left as unbound would be 1/3. So if 2/3 of our drug is bound, that means 1/3 of our drug will be left unbound. So that's a kind of an important concept here. Again, this is very simple math. This is a simplistic question, but it's important to understand. If 2/3 are bound, then 1/3 is unbound. Now we can actually calculate the A, or the alpha, for this drug. So we'll use that formula where we say the alpha is equal to the concentration unbound divided by the concentration total. So to set that up, I'll show you my work here. Using values from step 1 above, remember we defined essentially the unbound fraction as being 1/3. So we put 1/3 over, and we said the total in this case would be 1, representing kind of the 100%. So we essentially have 1/3 divided by 1, meaning our answer is 1/3. And if we divide that out into an actual numeral, that means that's equal to 0.33. So the alpha for this drug is 0.33. Now, what does that mean? How would we interpret it? Well, a value of 0.33 means 33%, meaning 1/3 of the drug concentration is unbound and available to actually produce its effect. So, while this wasn't a really highly complicated maths type of question, it shows you the process that we go through to analyze a drug to understand how much of it will be available, how much is unbound and therefore available. That can tell us and give us and compare A values to different drugs to look at relative differences in how well the drug will be able to leave the blood and get into the body, brains, livers, hearts, whatever it is, to be able to produce their effect. So it is kind of an important kind of review of the distribution aspect of pharmacokinetics. All right, this next question continues on the topic of distribution of the drug within the body, but in a different way. And it brings up a very important concept in pharmacokinetics called the volume of distribution. And volume of distribution is usually abbreviated as capital V and a little d. So if I sometimes revert back to just saying VD, I am referring to the volume of distribution. And really what this important concept represents is that we've been talking about absorption, and drugs get absorbed from the stomach and into the blood. Or if you give a drug intravenously, you're putting it directly in the blood. So after absorption, distribution occurs starting with the drug in the blood. But most drugs don't produce their effect in the blood. To have any effect at all, they have to be able to leave the blood, get out of the blood vessel, and get into tissues and organs to produce their effect. Okay, so what a volume of distribution is it's a theoretical. It's not even a real volume. It is what the volume of the drug appears to disperse in. Okay, so if a drug doesn't leave the blood, it can't get out, then it's going to have a very small volume of distribution. It doesn't seem to go anywhere. Whereas if a drug, it does a good job of being able to leave the blood and get into the organs and tissues where it can produce its effect, then it's going to have a relatively high volume of distribution. Okay, so hopefully that kind of makes some sense here. I know it's a difficult concept, and you'll certainly talk a lot about this in your pharmacokinetics course. But let me just, again, read you some quick definitions to follow up on what I said, and hopefully it'll make sense then when we do our math. So again, the volume of distribution, I'll reiterate, is a theoretical volume that would be necessary to contain the total amount of the administered drug at the same concentration that is observed in plasma. It is defined as the distribution of a medication between the plasma and the rest of the body. Now, the VD represents the degree to which it gets out of the plasma. The higher the volume of distribution indicates a greater amount of tissue distribution. A volume of distribution actually greater than total body water, which is approximately 42 liters in humans, is actually possible because tissues can actively concentrate the drug. Drugs don't just move passively through the body. So you can actually appear to have a drug go into a volume that's greater than the total volume of water in humans. Okay? So again, in rough terms, a drug with a high lipid solubility, which are nonpolar drugs, or drugs with low rates of ionization and low levels of plasma protein binding capabilities, are the types of drugs that have these higher volumes of distribution. Conversely, drugs that are more polar or more highly ionized or exhibit a higher degree of plasma protein binding in the body can't leave the blood, have a much more difficult time leaving the blood. Therefore, they're the drugs that are going to actually have a much lower volume of distribution. So, with that in mind, enough of a background, hopefully, to understand why this would be an important parameter to be able to calculate. Okay, so let's read the question and then we'll talk about the equation, and you can kind of see why we need some of the information provided to us in the question. So the question reads, the volume of distribution, or VD, for a drug has been determined to be 34 liters. Calculate the expected drug plasma concentration of the drug in micrograms per deciliter immediately after an intravenous dose of 5 milligrams. Okay, so they've actually given us a volume of distribution and they've given us a dose of 5 milligrams. What does it want? It wants to know, and it's kind of interesting, it wants us to predict the concentration we will get in the plasma after we give a 5 milligram dose. And we can only know that if we also know the volume of distribution, because looking at the equation below, and this is kind of the famous important equation in pharmacokinetics you need to know for the volume of distribution. That is, the VD is equal to the dose, which is capital D, divided by the resulting plasma concentration, which is abbreviated as capital C with a little p for concentration in the plasma. So VD equals dose divided by plasma concentration. So with that formula, you can go and calculate any of those parameters. So let's go ahead and apply that to this question. Because rewriting some of that information here, we were told the dose is 5 milligrams. What's also important to know is that dose was given intravenously, so we can assume 100% absorption. There is no absorption. All of that dose was given directly into the blood. We were also told that the volume of distribution was 34 liters. So now we're going to calculate for the plasma concentration. So the first step is to, and I'll remind you, it wanted the plasma concentration in specific units of micrograms per deciliter. So let's do one thing at a time. First step, let's convert our dose from milligrams to micrograms. And that's pretty straightforward math. I show you the equation here. We're going to take our 5 milligrams times 1,000 micrograms for every 1 milligram. And you can see the units of milligrams cancel, so we have 5,000 micrograms. Okay. Step 2 is to convert the volume of distribution we were given from the units of liters to deciliters. Okay. Again, relatively straightforward math. We're going to start with our VD of 34 liters, and we're going to multiply it by, but I will warn you, many students have a hard time converting from liters to deciliters for some reason, because it's not as common a volume to use unit-wise. But in the end, if you think of the deci, centi, milli, there are essentially 10 deciliters for every 1 liter. Therefore, when you multiply it in this way and liters cancel, giving us deciliters, 34 times 10 would be 340 deciliters. Okay. Now we can go to step 3, which is actually solving this question, which is to determine the plasma concentration using this information. To do that, just being very methodical step by step here, we have to start back with the original equation I gave you, which was that the volume of distribution was equal to the dose divided by the plasma concentration. But we want the plasma concentration, so doing one step at a time, let's multiply both sides by CP, or plasma concentration. So that would give us VD times plasma concentration on the left, equal to just dose on the right, since the plasma concentrations would cancel there. Now, since we want plasma concentration, let's divide both sides by the volume of distribution. So that now gives us on the left hand just plasma concentration, and we would set that equal to now the dose divided by the volume of distribution. So hopefully all of that was just so you can maybe see that I'm just rearranging that formula now, because now I have a formula for the plasma concentration, and it's equal to the dose divided by the volume of distribution. So now if I just plug in my numbers, remember that we calculated the dose to be 5,000 micrograms, and we divide that by the volume of distribution as 340 deciliters, we can see that the plasma concentration that would result is 14.7 micrograms per deciliter. And that is the answer to this question. And it just is an interesting question to remind you that if you know the volume of distribution, then you can predict a resulting plasma concentration from really any dose of the drug. And that's sometimes very important because certain drugs have a narrow therapeutic index. That is, we don't want the concentrations to go too high because it could become toxic, or we don't want to give too low of a dose because then we might not get a plasma concentration that's even effective for that drug. So again, a very useful term for dosing drugs in many instances. All right, this next question is closely related to the one we just did. It's going to be using the same formula for the volume of distribution, and it still relates to volume of distribution. But in this case, it's more about how to actually calculate the volume of distribution. In the previous question, it was given to us, so we saw how it could be used to predict a plasma concentration. But most of the time, you have to first calculate the volume of distribution to begin with. So how is that done? Pretty straightforward. But let's read the question to begin with. It says, if a 6 milligram dose of a drug is administered intravenously and produces a blood concentration of 0.4 micrograms per milliliter, calculate its apparent volume of distribution. Okay, so now this is what we're actually going to calculate for is VD. And so I've rewritten some of that information down there. Our dose is 6 milligrams. Plasma concentration that we get from that dose is 0.4 micrograms per mil. So using those two factoids, let's go ahead and calculate the volume of distribution for this drug in this patient. And before I go on, this is such a simple math question. I wanted to add a little more information. The vial I chose to show you on here for the 6 milligram dose is Celestone Soluspan. And there is an interesting history behind this particular commercial product. Keep in mind, Celestone Soluspan was the brand name of a product called beta-methasone combination. Beta-methasone is a corticosteroid used for their anti-inflammatory effects in all sorts of different disorders for different organ systems. But what's interesting about this commercial product is the company that made it, Shearing, actually ceased manufacturing this product in March of 2004, and it was actually moved from the prescription drug product list to the discontinued drug product list. And keep in mind, this was a drug that was commonly used for all sorts of disorders, so there was still a demand. The manufacturer never gave a very strong reason why they stopped making it, but they stopped making it. Why this is at all interesting is that it was the unavailability of this commercial product that led to the pharmacy called the New England Compounding Center to try to reproduce the formulation. Sadly, they produced some batches of the injection that were contaminated with both bacteria and fungus, and which led to multiple fatal cases of meningitis. And it created such a public uproar over what this compounding pharmacy had done that it ultimately led to major changes in the laws and the regulations of compounding pharmacy that affect us to this day. So just a little bit of interesting background for a drug vial that you can see where a dose would be 6 milligrams for 1 mil. Either way, let's continue on with this actual question. So I've rewritten that information here. The first step, though, is to make sure that our units match because our dose is in milligrams, but our plasma concentration is in micrograms. So step one, let's convert the dose from milligrams to micrograms. Easy math. Let's just start with our 6 milligram dose times the fact that there's 1,000 micrograms per every 1 milligram. Milligrams will cancel, and that means we have a dose of 6,000 micrograms. Step two is to actually solve for the volume of distribution using the formula. So I'll remind you, the formula that we were given was that the volume of distribution is equal to the dose divided by the plasma concentration. So if we put those actual numbers in, we can see that our dose was 6,000 micrograms. And we're going to divide that by the plasma concentration we got, which is 0.4 micrograms per milliliter. And when we divide that out, the math would turn out to be 15,000 milliliters. Micrograms cancel, and our units would be in milliliters. And lastly, because that is such a large number, oftentimes we will express then the volume of distribution in liters. So let's convert that to liters by simply multiplying it by the fact that in every 1 liter, there is 1,000 milliliters. So milliliters cancels. And you can see that our final answer then would be 15 liters. So by giving somebody a 6,000 microgram dose, and then measuring a subsequent plasma concentration at 0.4 micrograms per milliliter, we know that the volume of distribution for this drug in this patient is 15 liters. Why that is important is that in that patient, for that drug, whatever dose we give, we would always get that volume of distribution. Now, a different drug in that same person would have a different volume of distribution, but that drug in that patient, regardless of the dose, always has the same volume of distribution, which is very useful then because we can then, knowing that, be able to tailor different doses to get to specific plasma concentrations that we may want. What is important to know, though, is that the same drug in different people will have different volumes of distribution. So you can't assume that the volume of distribution observed in one patient would be the same in a different patient. But once you know it in a patient, you can use that information to tailor your doses to get to the specific plasma concentrations you want, which is a very powerful effect. All right, we have made it to the last question, and I love this question. It is a big kind of catch-all question that goes through, everything we've discussed up to this point, including a new topic of half-life, which has to do with the elimination process to pharmacokinetics. So before we get into this big, long question, just a little bit of background about the drug, because it's all based off of this drug Hydromorphone, which goes by the brand name of DILAUDID. And it's an opioid analgesic, and it's been around a long time. It was first marketed like around 1962. And, there are a lot of opioid analgesics. So what makes Hydromorphone kind of unique is that it's actually available in multiple dosage forms, IVs, tablets, many different ways that you can give it if it's needed. And it's typically reserved to treat relatively strong, either moderate to severe pain. Now, it is also the benefit to it is that hydromorphone is kind of useful in elderly patients and in patients with renal dysfunction, as opposed to using something like morphine, because drugs like morphine oftentimes have active metabolites that are renally excreted and can be problematic in the elderly or with renal disease. Now, hydromorphone has kind of a rapid onset of pain relief, especially compared to morphine, but also has a much shorter duration of action. And that's what limits its use in many patients with chronic pain. So it's one of our commonly used opioid analgesics, but unique in terms of its pharmacokinetics. So it makes for a good drug to use in this question. So let's look at all the detail in this question, and then we'll break down and answer each of the 4 questions one at a time. The question states that hydromorphone, or DILAUDID, has a bioavailability of 24% when given as an immediate-release tablet, and produces a Cmax, which basically stands for plasma concentration, but it's the peak or the maximum concentration produced. So Cmax of 5.5 nanograms per milliliter at approximately 45 minutes following administration. Now, the volume of distribution for this drug is 2.9 liters per kilogram, and the elimination half-life is 2.6 hours. And the drug is approximately 14% protein bound. Okay, so there's all this information given to us, it seems like in a little bit of random order. So I'm going to skip over the specific questions for now. We'll get to those one at a time. But let's rewrite this information. And let's use some of the terms and the abbreviations that we have learned so far in this little chapter on pharmacokinetics. So some of the information they gave to us was, let's start with the dose. Remember, we'd say capital D for dose, and that was equal to 8 milligrams. They also gave us a bioavailability, which we said we'll use as a capital F for bioavailability factor, was 24%. They told us that the drug was protein bound at 14%. And remember, that was something that we'll use when we calculated our alpha. Okay, and so we'll get back to that with the protein binding, but it's 14% protein bound. They also gave us a volume of distribution, or VD, of 2.9 liters per kilogram. So keep that in mind. A little bit of different units here. 2.9 liters per kilogram. At a Cmax, or a plasma concentration, was 5.5 nanograms per milliliter. And lastly, a new term they introduced was half-life. That the half-life, which is often abbreviated as T with a subscripted 1/2, so T1/2, half-life, is 2.6 hours. And I'll talk more about that later here. So with that information, let's go through these questions one at a time and go through kind of a variety of different pharmacokinetic parameters. The first one we'll go back and revisit was bioavailability, because the first question wants to know the amount of drug absorbed from an 8 milligram tablet based on the drug's bioavailability. So to do that, we set up this formula. Remember, we take the dose, which we said was 8 milligrams, and we multiply it by its bioavailability factor, which they gave to us as 24%. So what we'll use that, express that in its numeric form at 24%. 24 divided by 100 is 0.24. So we're going to put the factor, the bioavailability factor of 0.24. So we multiply 8 by its bioavailability factor of 0.24, and we see of that total 8 milligrams, only 1.92 milligrams is going to be absorbed and get into the blood. Okay, so 1.92 milligrams gets into the blood based off of this tablet's bioavailability. Okay, next question wants to know the amount of unbound drug based on the amount absorbed in the first question. All right, so this gets back to plasma concentrations and bound versus unbound as far as the distribution goes. So the formula we used back then was that the concentration total was equal to the bound concentration plus the unbound concentration. So what we know in this question is that, well, regardless of what the actual total amount is, essentially 100% of whatever makes it into the blood, okay, the total concentration, whatever it is, the 100% of that is going to be equal to the two different portions. The portion bound, which they told us here that the bound portion was 14%. So 14% will be bound, which leaves whatever is left as the unbound concentration. And since we know the total, obviously, for whatever it is 100%, and that 14% is bound, the remainder would be unbound. So if we solve for the unbound by simply subtracting 14 from 100, we would see that the unbound percentage would be 86%. Now we can use that 80%, which represents the concentration unbound, and apply it to the total amount that was absorbed, which we know from the previous question was 1.92 milligrams. So we take that same answer from letter A and now multiply it by essentially 86%, expressed as a numeral meaning 0.86. So 1.92 times 0.86 means that of the 1.92 milligrams total absorbed, only 1.65 milligrams remains unbound. And why that is important is that's the dose, that is the unbound dose, that is available to produce its effect in the body, because the others are bound and not available. All right, moving on to the third question. It asked to determine the total amount of drug in milligrams present in a patient who weighs 160 pounds at the time of the Cmax, or the plasma concentration maximal, based on the VD provided to us. Okay, so it's kind of a complicated question, so let's go through this one step at a time. And you'll see there's a lot of issues here with units. We're going to have to be very careful with our units. So let's start, though, with the volume of distribution equation, because remember, what it wants us to solve for is the amount of drug. That would be the dose, okay? So we're trying to solve for essentially the dose here. So let's use the volume of distribution formula to do that. So if VD, or volume of distribution, is equal to the dose divided by CP, we could rearrange that as saying that, well, if we just multiply both sides by the plasma concentration, then the VD times the plasma concentration would equal the D, or the dose, okay? So now we were given a plasma concentration, the Cmax. Now, before we do anything else, all I'm doing in this step is getting our units of Cmax to match the units that we're eventually going to want for our drug dose, which is in milligrams. So let's start with the fact that our plasma concentration, our Cmax, was 5.5 nanograms per milliliter. And nanograms is not a very frequently used unit. It's a very small unit. Some drugs are measured in those small units, but it's sometimes more difficult to work with. So all we want to do is convert nanograms to milligrams. But even I can't do that in one step. So what I like to do is multiply my nanograms by the fact that what I can remember is that in 1 microgram, there are 1,000 nanograms. So now nanograms will be converted into micrograms. Then I can take the next step to convert micrograms to milligrams because I know in 1 milligram, there's 1,000 micrograms. Okay, so if I do all of that math, you can see what very small number we get here, but now the units are in milligrams per milliliters. Okay, the only additional pre-step we have to do relates to our volume of distribution because we have our CP now expressed in milligrams per mils. Now we need our VD that we can use to determine the dose. Problem is, they gave us the volume of distribution in the units of liters per kilogram. So we have to take into account the patient's weight to know what their total volume of distribution is. So let's start with the patient's weight, which was given to us at 160 pounds. We're going to multiply that to convert to kilograms by the fact that in every 1 kilogram, there are 2.2 pounds. So pounds will cancel. Then we can multiply that by the fact that we were given the VD as 2.9 liters per kilogram. So now kilograms will cancel and will be in liters. The problem, I'll remind you, was that our plasma concentration is given to us in milligrams per milliliter. So I want to go further and convert my liters to milliliters by multiplying by the fact that there's 1,000 milliliters per liter. Now, if I do that math all the way across, again, I get a large number, 210,909 milliliters as my volume of distribution. So now, and the whole point of both of these two steps so far was simply to convert my concentration from nanograms per mil into milligrams per mil, and to convert my volume of distribution from liters per kilogram into just milliliters, because my last step in my formula was just to multiply the volume of distribution times the plasma concentration. Now I can do that. My volume of distribution was given at 210,909 milliliters, multiplied by my concentration there expressed in milligrams per milliliters. Now milliliters cancel and my final units will be in milligrams. So if you do that math, you should get 1.16 milligrams. And that is the dose. That represents the drug that this was given to this patient, to get the Cmax that we did. All right? So moving on to the last question is a new topic. So the question is the amount of time necessary to eliminate virtually all of the drug from the body. Okay, so we've talked about absorption, distribution. Now, we didn't do much with metabolism, but going to the end, the last D, or after metabolism, is an E, which stands for either elimination or excretion. So removal of the drug from the body. All right, and half-life is a common pharmacokinetic parameter to express that. So in a half-life, T1 half is essentially the time it takes for the drug concentration in the body to fall by 50%. So after that amount of time, whatever concentration you started with is now half of what it was. Okay, and so you can kind of see these figures. This graph I show you here on the left-hand side shows you serum concentration on the left and on the y-axis, and then on the x-axis is the time in half-lives. And there are two graphs here because it's a little bit confusing, but if we look at the graph on the top left that starts at 1, that's the amount of drug concentration remaining. And so we start at 1, or 100% at time 0. And then going from left to right in half-lives, you can see after one half-life, we've gone from 1 down to 0.5, because in one half-life, we eliminate 50% of our concentration. What you're seeing and so you can see that progress from the curve going from 1 all the way down towards 5 and falling in concentration is our remaining concentration. The line that starts at 0, 0 and goes up is the amount eliminated. And you can see as more is fallen or removed from the blood concentration, then the amount eliminated goes up. in the end, all this really matters is when you get into pharmacokinetics, what you'll learn is that if you do the math with this percent lost and the amount of half-lives, is this last statement, is that after 5 elimination half-lives, it is expected that virtually all of the drug, meaning 97% of what you originally started with, will be eliminated. And that's kind of shown you in the graph, but just understand this. What we learn in pharmacokinetics is that it takes about 5 half-lives to completely eliminate the drug. But we know that completely eliminate isn't quickly right. We say virtually all of the drug because that means 97%. There's still a little bit left, but usually so little that it wouldn't be expected to produce any biologic effect. So after 5 half-lives, we've lost 90% of our concentration, which means that virtually there's no active drug left. Which makes this last question relatively simple once you know that fact. Because all we're going to do is start with the fact that I just told you that after 5 half-lives, it's almost all gone. So we're going to take 5 half-lives times what they told us for our drug, for Hydromorphone, the half-life was 2.6 hours. So 5 half-lives times 2.6 hours per half-life means that essentially after 13 hours, 97% of our starting concentration of hydromorphone will have been eliminated from the body, and essentially there would be no effect remaining. All right. So hopefully you found this interesting. And again, this was not supposed to be a podcast about to make you an expert in pharmacokinetics. You're going to have a lot more detailed information on all that. But it was to show you how important your math skills will continue to be as you apply them in different aspects to pharmacy. And in this case, it was all about the pharmacokinetics and this issues of math and mathematical equations used to describe absorption, distribution, metabolism, and elimination.